ஒரு ஆளுக்கா ஸ்டார்ட் பண்ணுறேன். அது யூடியூப் லிங்க் கனெக்ட் பண்ணுறேன். ஸ்டார்ட் ஆயிடுச்சு. Hello everyone, very good evening to all. I welcome you all to this MDS rapid revision session for INI-CET. So this is going to be a quick review of the recent papers, the recent PYQs, not only the PYQs but also the previously asked topics, not only the previously asked questions but also previously asked topics. Let's quickly look at recently asked May 2025 question. So this was a question on high altitude. What are the changes in high altitude? So I think the audio visuals are fine. Yes. So this was a question on high altitude. What is the sudden change happening in high altitude? So when you go to high altitudes, a high altitude place means on top of a mountain. What is the change that is happening as you go higher and higher? So as you go higher and higher on top of a mountain, the atmospheric pressures are less. So on top of a mountain, the atmospheric pressure is less. So when I say atmospheric pressure is less, it means the partial pressure of gases are low. Partial pressure of oxygen is less. When partial pressure of oxygen is less, this is called as hypoxia. So on top of a mountain, there is hypoxia. Hypoxia is a very potent stimulus for peripheral chemoreceptors. Where are the peripheral chemoreceptors located? On the arch of aorta and at the bifurcation of the internal carotid artery. So that is the location of the peripheral respiratory chemoreceptors, which are very, very sensitive to hypoxia. And this hypoxia stimulates the peripheral chemoreceptors. Once they are stimulated, immediately we do breathing. You do more of breathing, more stimulation of peripheral chemoreceptors. There is an increased response of breathing. So you begin to hyperventilate. So you breathe more when you are on top of a hill. So this is called hyperventilation. Hyperventilation. What is the effect of hyperventilation? As a result of hyperventilation, when you breathe more, you send out more CO2. There's a carbon dioxide washout, because breathing itself is a process of pushing out the CO2. When you breathe more, you are sending more CO2 outside. So there's a CO2 washout. When CO2 goes out, carbon dioxide is considered as a acid, because on the process carbon dioxide forms carbonic acid. So CO2 itself is a volatile acid. So acid is washed out of the body. There's washout of acid. When acid goes out of the body will go for alkalosis. When acid moves out, inside the body there is alkalosis, and this is called respiratory alkalosis. Very important concept and repeatedly asked topic also. So on top of a mountain there is hypoxia. Hypoxia stimulates peripheral chemoreceptors. Once peripheral chemoreceptors are stimulated, you begin to breathe more. You send out more carbon dioxide acid from your body. Body goes for alkalosis. This is called respiratory alkalosis. So the next high yield question, recent INI-CET paper, was on characteristics of UMN lesion and LMN lesion, upper motor neuron and lower motor neuron. First, let's understand what is an upper motor neuron and what is a lower motor neuron. The upper means the neurons that are located up are called upper motor neurons. From brain to spinal cord, up in the sense from brain to spinal cord, they are called upper motor neurons. Lower motor neurons are located lower. So this means lower motor neurons from spinal cord to muscles, they are located low. From spinal cord to muscles, they are called as lower motor neurons. So upper motor neurons and lower motor neurons. if there is any damage to the upper motor neurons, that's called a UMN disease. And if there's any damage to lower motor neurons, it's called as a lower motor neuron disease. What are the examples for upper motor neuron diseases? Which is the major upper motor neuron? Corticospinal tract is the major upper motor neuron. So example for upper motor neuron disease, corticospinal tract lesion, or that's called hemiplegia. Corticospinal tract lesion results in hemiplegia. So hemiplegia is the most common example for UMN lesion. What about LMN lesions, lower motor neuron diseases? This means the nerve innervating the muscle is going to be affected here. So basically muscular diseases like poliomyelitis or muscle dystrophies or muscle atrophy. These are examples for lower motor neuron diseases. Now what are the clinical findings in UMN and LMN? So one easy way of doing this is upper motor neuron lesions. Three things are up. What is up in upper motor neuron lesion? Tone is up. That's called hypertonia. Reflexes are up. That's called hyperreflexia. And when you do a Babinski sign, the toes go up. Babinski sign is when you scratch on the sole of the foot from lateral to medial, the toes go low. Usually the toes go down like this. But in UMN disease, upper motor neuron disease, the toes go up and they're fanning out like this. That is called Babinski sign positive. So upper motor neuron disease or upper motor neuron lesions, three things will be up. Lower motor neuron disease, three things are low. What is low? Tone is low. That's called hypotonia. Reflexes are low, hyporeflexia. And when you do a Babinski sign, toes go low. So the toes go down like this. That's a negative Babinski sign seen in LMN disease. There is another disorder, and this man was affected by this disorder. Who's this man? Yes, Stephen Hawking. What was the disease he was suffering from? Yes, that's called amyotrophic lateral sclerosis, which is a disease common to both UMN and LMN. ALS could affect both UMN and LMN. And a baseball player named Lou Gehrig, he was also suffering from the same disease. So this disease is otherwise called as Lou Gehrig disease. This is both UMN and LMN. So characteristics of UMN lesion, toes go up, Babinski sign positive. Others are all features of lower motor neuron lesion. Tone decreases in lower motor neuron lesion. Fasciculations are typical presentations of lower motor neuron lesions. Fasciculation means muscle fibers will contract. The muscle will not contract in LMN lesion, but the previously stored pockets of acetylcholine may be released, and there's a small contraction of one or two muscle fibers you will see. As such, the muscle will not contract, but individual fibers could contract. Flaccid paralysis. So all these are seen in LMN lesions except positive Babinski sign, which is seen in UMN lesion. The diluent fluid used for total RBC count. Yes, nowadays we have questions from practical lab physiology also. So this is the method of counting your own cells. Let's quickly see what are the different fluids which are used here. RBC count. For the red blood cell count, we use Haynes fluid or Gower's fluid. WBC count, Turk's fluid. Platelet count, Rees-Ecker fluid or ammonium oxalate. Eosinophil count, that's called the Dungus fluid or Pilot's fluid. And for reticulocyte count, brilliant cressyl blue, it's a supravital stain. So these are the clinical laboratory techniques where we use this particular fluid for counting that particular cell. So the answer to this question, diluent fluid for RBC, yes, it is the Haynes fluid. Capacitance vessels are, in the entire vascular system, we give a special name for each of this blood vessel. Aorta. Aorta is the largest blood vessel, and this is called as the Wind-Kessel vessel. And the effect that happens in the aorta is called Wind-Kessel effect. Wind-Kessel effect is, aorta is a large structure, it is a highly elastic structure. Whenever heart pumps blood into the aorta, aorta can expand, it will hold the blood, and because of its elastic nature, it will recoil back. when the aorta recoils back with a great force, that is going to pump blood to every part of the body. That's called the Windkessel effect. Windkessel are big reservoirs near the dams. When water flows out from the dam, Windkessel reservoirs will store this and they will pump this water to every part of the place. So like that, when heart pushes the blood, aorta acts like a Windkessel, holding the blood and pumping it into other parts of the body. What are large arteries called as? Distribution vessels, because they distribute blood to all parts of the body. Arterioles are called resistance vessels because they have smooth muscles. When smooth muscles constrict and relax, that gives a resistance. Capillaries are called exchange vessels because capillary fluid shift. The exchange happens at the level of capillaries. And veins are called capacitance vessels because veins have a huge compliance. Compliance means the property to stretch. Veins can stretch a lot and they can hold a lot of blood. At any point of time, 64% of total blood volume is present in the veins. So arteries are highly elastic, whereas veins are highly compliant. These are the different names given for the vascular system. So capacitance vessels are, yes, veins are called capacitance vessels. Phase 2 of ventricular action potential is due to. So this is about the cardiac ventricular action potential. Again, action potential is a very high yield topic. So let's quickly learn about action potential. This is the action potential curve. Before learning cardiac ventricular action potential, first let me tell you about the nerve action potential, because this is the basic action potential. Nerve and skeletal muscles have the same type of action potential. What are the major events that take place in the action potential curve? Time in milliseconds on x-axis and membrane potentials in millivolts on y-axis. So this is a relation between membrane potential and the time. Over time, if you excite a cell, if you stimulate a cell, if you give any current to an excitable cell, the cell will show all these different changes in the membrane potential. It will become positive, negative. So those potential changes are called as action potential. Initially, the cell is in rest. So this is called as the RMP or resting membrane potential. First, it is at rest. And RMP is mainly due to potassium ion concentration, because at rest all channels in the cell will be closed. Only potassium channel will be open. So only potassium can move. That is why RMP depends on potassium ion concentration, because at rest only potassium channels are open. The cell is most permeable only to potassium. Now I am going to stimulate this cell. It is going to show a sequence of potential changes. That's called action potential changes. So initially there's a small phase, local potential, when few sodium ions enter inside. Initially only 1 or 2 sodium ions enter inside. When few sodium ions enter inside, sodium is a positive ion. So there's a small increase in positivity. So that's why it goes from here to here. A small increase in positivity. This is called local potential, and local potential is due to opening of few sodium channels. And the entry of this few sodium channel will stimulate the entry of many sodium ions into the cell. This is called the positive feedback of Hodgkin's cycle, where one sodium entry stimulates the entry of many other sodium channels. Sodium ions come inside. This is a positive feedback. One is enhancing the effect of the other. One sodium is increasing, it's stimulating other sodium ions to come inside. So when suddenly so many sodium ions come inside, there's a rapid increase in positivity. So the curve goes like this. This is called depolarization phase. And depolarization is due to sodium influx. Suddenly so many sodium ions are coming inside. That's called sodium influx. And this reaches a positivity of, it will cross even 0, it might go even up to plus 35. And after that there is potassium efflux, which is called repolarization. Potassium ions are moving out. Potassium is a positive ion. When positive ion goes out, the cell becomes negative. So when it is returning back to negativity, it's because of potassium efflux. So depolarization due to sodium coming inside, and repolarization due to potassium going out. Influx, efflux. So this started at RMP. It should stop at RMP, but it is not stopping at RMP. It goes even beyond RMP. So it's going beyond, it's crossing RMP. So it's called hyperpolarization. So this phase is called hyperpolarization. It goes even beyond RMP, hyperpolarization. And again it comes back to RMP. So these are the changes that take place in the nerve action potential. Now let's see what's the difference between nerve action potential and cardiac action potential. Cardiac muscle has two different type of tissues, the normal cardiac ventricles and the SA node. So there are two different type of action potential curve, the normal cardiac ventricle action potential and the SA node action potentials. What are the changes that take place in the normal cardiac ventricle action potential? So in a normal cardiac ventricle action potential, this one, this is same as the nerve, almost same as the nerve. Depolarizations, there is a depolarization due to same as nerve, sodium influx. And there's a repolarization. Initially there's a transient repolarization, phase 1, and in phase 3 there's a complete repolarization. So this is repolarization where potassium moves out. This is called potassium efflux. This is also same as the nerve, but in between these two phases there is a plateau phase, a flat phase or a plateau phase, and this is due to opening of L type of calcium channels. Now why is there a plateau phase? Just imagine when there is going to be repolarization, potassium goes out. Initially in phase 1 potassium begins to move out. So potassium, one positive ion goes out, and in phase 3 completely potassium is going to move out. But only during this phase 2 there is opening up of long lasting type of calcium channels and calcium enters inside. Potassium, one positive ion is moving out, calcium, one positive ion is moving in. Both will balance each other. One is moving out, one is moving in. Both the positive ions balance each other, and that is why there is no electrical activity happening and it becomes flat. That's called the plateau phase. And after that there is a complete repolarization and it reaches the RMP value. This is special about cardiac ventricle action potential. What about SA node, the pacemaker potential? In pacemaker potential, the depolarization phase itself is due to calcium influx, calcium coming inside, calcium influx, and this is due to opening of long lasting type of calcium channels, L type of calcium channels. So because SA node, it lacks sodium channels and there are plenty of calcium channels, depolarization itself is due to calcium influx and not sodium influx. So this is one exception in the body where depolarization is due to calcium influx. The other exception where depolarization is due to calcium influx is smooth muscle. So SA node, smooth muscle. Depolarizations are due to calcium influx. There's another exception where depolarization is due to potassium influx. Where is that? Yes, in the ear, in the inner ear, in the scala media, that's called as a cochlear structure. In the cochlea, scala media has the organ of Corti, and this scala media is rich in potassium. So it allows potassium ions to go into the hair cells, and that will cause action potentials. So the only exception in the body where depolarizations are due to potassium influx is in the ear. Another special thing about SA node action potential is this slopy phase, phase 4. This we call as pacemaker potential, pacemaker potential, or slow diastolic depolarization, slow diastolic depolarization or pacemaker potential. That's the phase 4. These are the special points about SA node action potential. Going back to the question, phase 2 of ventricular, yes, what is phase 2 of ventricular due to? Yes, long lasting type of calcium channels. So this is calcium channel, to be very specific. long-lasting type of calcium channels. The next question, this is a high yield topic on pain physiology. Repeatedly we see questions from pain physiology. A dull continuous pain which patient is not able to localize is due to which of the fiber? Basically, spinothalamic tract carries your pain. There are two types of spinothalamic tracts because there are two types of nerve fibers which carry pain. A delta fibers and C fibers. A delta carries fast pain whereas C fiber carries slow pain, because the property of A delta, A fiber is that it's a fast fiber, C fiber is a slow fiber. So that is why the A delta pathway carries fast pain, first pain or epicritic pain, whereas C pathway carries slow pain, second pain or protopathic pain. Now A delta pathway, the pathway itself is a very specific pathway. It will not give any diffuse branches. The pathway is very localized and specific. It starts in a place and it ends in a place. It does not give any diffuse branches inside. That's why the pain is also specific and localized. Example, needle prick injury, electric shock injury. If you have a needle prick injury in your tip of your finger, only in the tip of the finger you will have the pain. Only in that area you will have the pain. You will not experience pain in any other part of the body because the pathway is very specific. But the C pathway, it gives many diffuse connections, many diffuse branching in the midbrain points and medulla. That's why, since the pathway itself is very diffuse, the pain is also diffuse. So that carries diffuse pain. Example, visceral pain. Visceral pain, any pain arising from your viscera, your gastritis pain, menstrual pain or renal colic pain, any pain which comes from inside the viscera is a visceral pain. The neurotransmitter for A delta pathway is glutamate. It's a specific pathway, localized pathway. So one neurotransmitter, glutamate, is enough. But C pathway, it's a diffuse pathway. It has to go to many areas. So one is not enough. You need one more. Along with glutamate, you need substance P also. A delta pathway, it's a fast pathway. Fast means new. So that's called the neospinothalamic tract. C pathway is a slow. Slow means older. So that's called the paleospinothalamic tract, the older pathway. Pain physiology and the different types of pain and pain pathways, high yield topic. Dull continuous pain which the patient is not able to localize. Slow pain is usually called as diffuse dull type of visceral pain. So dull type of pain, visceral pain, diffuse pain is carried by, yes, C fibers, C fibers. And you are not able to localize because the pathway itself is very diffuse. The pain also will be very diffuse. If you have a stomach pain, can you point out and say only here it is paining? It's very diffuse. You cannot point out and say. You will not know where it's paining. It's a diffuse type of pain. So this next topic on respiratory physiology. Maximum amount of carbon dioxide is carried in the blood as. So this is about transport of oxygen and carbon dioxide. Transport of oxygen. First let's do oxygen. If this is any alveoli, this is your alveoli. On the other side of the alveoli, you have the blood vessels. So the blood vessel which is in close contact with the alveoli is, yes, the pulmonary capillaries. So gas exchange takes place between alveoli and the pulmonary capillaries. Oxygen enters into the pulmonary capillary. When we inhale, oxygen enters into the blood. What is the fate of this oxygen? This oxygen enters into the pulmonary capillary red blood cells, RBCs, and inside the RBC, 97% of this oxygen combines with hemoglobin, and this is called the bound form of oxygen. The bound form, because it is bound to hemoglobin. So the major transport form of oxygen is along with hemoglobin, and this will be carried to different tissues of the body. What about the fate of the remaining 3% oxygen which did not enter into the RBC? It stays in the plasma itself as a dissolved form. It is dissolved in the plasma. According to Henry's law, dissolved form of any gas is directly proportional to its partial pressure. So what is the role of this 3% dissolved gas in the plasma? This is what contributes to partial pressure. This 97% which is bound to hemoglobin cannot contribute to partial pressure because it is taken to all the tissues. Only this 3% dissolved form of the gas contributes to partial pressures. So that's called as the Henry's law. This is the fate of or transport of oxygen. What about the transport of carbon dioxide? Carbon dioxide, when tissues release carbon dioxide. Tissues release carbon dioxide into the venous blood. So this is venous blood. What is the fate of this carbon dioxide? Carbon dioxide, on entering into the venous blood, this enters into the venous blood RBCs, the red blood cells of the venous blood. And this carbon dioxide combines with water to form carbonic acid, which will split into H plus and bicarbonate. What is the fate of this bicarbonate? Bicarbonate moves into the plasma. Bicarbonate is an anion. So when one anion moves into the plasma, to balance for this, another anion, chloride, enters inside, and this is called Hamburger's shift. Hamburger's shift or bicarbonate chloride anion exchanger. When chloride enters into the RBCs, this is going to pull water into the RBCs. So there's more water into the RBC. So venous blood RBC has more water than the arterial blood. That's why venous blood hematocrit will be more than the arterial blood hematocrit. You take a packed cell volume. Hematocrit means packed cell volume, the volume of cells. The venous blood cells, the RBCs, the packed cell volume is more because of this water. So venous blood packed cell volume or hematocrit is 3% more than the arterial blood packed cell volume or hematocrit. That's a fact. And the reason for this is Hamburger's shift. How much of carbon dioxide is transported? Like this, almost 70%. Maximum transport of CO2 in the form of bicarbonate. The remaining 23% of CO2 combines with hemoglobin to form carb amino compounds. So this is the fate of 23% of carbon dioxide. 70 plus 23 is 93. What about the remaining 7%? Remaining 7% stays in the plasma as a dissolved form. According to Henry's law, dissolved form of any gas is directly proportional to its partial pressure. So this will contribute to partial pressure of carbon dioxide. So the major transport form of CO2 is, yes, as bicarbonate. Maximum CO2 is carried in the blood as bicarbonate. Next, let's discuss about RMP in a myelinated main fiber. Myelinated fiber is mainly due to, yes, we have already discussed action potential. So we discussed that RMP is mainly regulated by potassium ions because at rest the cell is most permeable only to potassium ions and not to any other ion. All other doors will be closed. Only potassium doors are open. So that's why the answer is potassium. Next, there was a 2021 repeat question on complicated problem based on this action potential. Nernst potential of a negatively charged ion, concentration of which in extracellular compartment is 100 and intracellular compartment is 10. So the question is about Nernst potential. Quickly let's discuss what is Nernst potential. All ions keep moving across the cell. Why ions are moving? To reach the equilibrium potential. All ions keep moving just to reach the equilibrium potential. Once they reach the equilibrium potential, the movement of the ion will stop. So every ion moves in order to reach its equilibrium potential. And that equilibrium potential can be calculated by using the Nernst equation. What is the Nernst equation? Equilibrium potential for any ion is equal to plus or minus 61 into log of C1 divided by C2. C1 is concentration of the ion in one compartment divided by concentration of the ion in another compartment. What are the two compartments here? ICF and ECF. But this can be ICF by ECF, or it can be ECF by ICF. Both are correct, because anyways you're going to take a logarithm. Log 1 by 10, log 10 by 1. Both will give you 1 only as the answer. So you can place anything on top. To make it easy, we'll place the bigger number on top. So it's log of the bigger number by the smaller number. It could be ICF or ECF, whatever it is, because anyways when we take a logarithm, the value is not going to change. And also we have a plus or minus. So we'll determine the sign separately. So let's do this for this particular question. Nernst potential of a negatively charged ion. So already they have mentioned that it's a negatively charged ion. Extracellular compartment is 100 and intracellular compartment is 10. So this is a cell with its intracellular fluid and extracellular fluid. Extracellular concentration is 100 and intracellular concentration is 10. Now how will this ion move? Any ion will move always from its high concentration to its low concentration. So this one is going to move from 100 to 10. Obviously from 100 to 10 only. So from its high concentration of 100 to its lower concentration of 10. And in the question it is already mentioned that it is a negatively charged ion. So a negatively charged ion is moving from ECF to ICF. Why is this ion moving? To reach the equilibrium potential. So when it reaches the equilibrium potential, we'll see what that ion has done to the inside of the cell. With whatever charge that ion has added to the inside of the cell, so that will be the charge of the Nernst potential. That ion is adding a charge into the cell. We will see what charge the ion is adding into the cell. A negative ion is moving from outside to inside. So this will create a negativity inside. So at equilibrium, this ion is making the inside negative. So we have determined the answer to be negative. Nernst potential, the answer should be negative only, because Nernst potential is whatever charge that particular ion has added to the inside of the cell at equilibrium. So this is negative. Now based on the formula, let's find out the answer. Plus or minus 61 into log of C1 by C2. What are the two concentrations here? 100, 10. So this is 100 by 10. 100 by 10 would be 10 and log 10 would be 1. So the answer is plus or minus 61 into 1. So this is plus or minus 61. So we have determined to be plus or minus 61. And we already know that it is minus. So what is the answer? Minus 61. So when you want to choose plus or minus 61, the answer is minus 61. Why? How did we get this minus? Minus was the charge which was added by that particular ion. So from Nernst potential equation, you will get the answer as plus or minus, any value, but it will be plus or minus. So if you have to find out whether it is plus 61 or minus 61, then you apply this concept. This is a negatively charged ion which is moving from 100 to 10, from outside to inside. A negatively charged ion, when it comes into the cell, at equilibrium potential, it will make the inside negative. So the answer would be minus 61. So we go for minus 61. Yes, can you tell me if the question was Nernst potential of a positively charged ion? The same question, but instead of negatively charged ion, if the question was positively charged ion, then what would be the answer? So you will get the same 61, but when you want to determine plus or minus 61, now it is a positive ion which is going to move from 100 to 10. So when a positive ion moves from outside to inside, this will make the inside positive. So at equilibrium potential, what charge that ion is giving to the inside of the cell? Positive. So now the answer would be plus 61. If it is a negatively charged ion, it's minus 61. If it was a positively charged ion, then you will get the answer as plus 61. Let's quickly learn about static lung volumes and capacities. There are different lung volumes and capacities. Static means you just measure in liters. It is not measured over time. When you measure it over time, that's called as dynamic lung volumes and capacities. This is just static, only in liters. What are the different static lung volumes and capacities? First, let's do a tidal volume. So when you do a normal breathing, say I'm doing a normal involuntary breathing, during a normal quiet breathing, you don't put any effort. You can't put any effort. Just during a quiet breathing, how much of air moves in or moves out? That's called tidal volume. So I'll trace the tidal volume now. So this is tidal volume during inspiration, expiration, inspiration, expiration. So this is the normal tidal volume. So the value of normal tidal volume during inspiration and during expiration is 500 ml. So inspiratory tidal volume is 500 ml and expiratory tidal volume is also 500 ml. Now at the end of this tidal volume, 500 ml has gone inside. At the end of the tidal volume, now you take a deep inspiration. When you breathe like that, now you can take in 2 liters. So this is 2 liters. Above tidal volume, how much air you can take in by a deep inspiration? That's called inspiratory reserve volume of 2 liters. Now let's do on the expiratory side. At the end of normal tidal volume expiration, now you do a deep expiration. Like that, if you send out the air, you can send out 1 liter. So expiratory reserve volume is 1 liter. Inspiratory reserve volume was 2 liter, but expiratory reserve volume is only 1 liter. What has happened to the remaining 1 liter? The remaining 1 liter did not come out. It stayed inside the lung itself as a residue. This is called residual volume of 1 liter. You add all this. A total of all this would be total lung capacity of around 5 liters. Not 5 to 5.5 liters. Of all these, the residual volume did not come out. So you leave the one which didn't come out and you add all others, that will give you vital capacity. So vital capacity is the sum of all volumes except residual volume. Because it didn't come out, we leave it. You add the ones which came out, the vital capacity around 3.5 to 4 liters. So that's the vital capacity. This is how we record the major volumes and capacities. And what is the name of the technique that you do this? Have you done this? Yes, that's called as the spirometry, a spirometer. This is a digital spirometer. In a spirometer, when you just put it's a small tube which you put into your mouth and you have to breathe into the tube. When you breathe into the tube, whichever air that goes into the tube, that's connected to the monitor, and the monitor will draw this graph for you. It will give you all the volumes and capacities. So a spirometry can measure all lung volumes and capacities except residual volume cannot be measured by using this spirometry because residual volume didn't come out at all. Whichever volume of air comes out and goes into the tube, the machine will record. But whichever air did not come out, residual volume didn't come out at all. Only if it goes into the tube, the machine can record. But residual volume didn't come out at all. So residual volume cannot be measured by spirometry. If you cannot measure residual volume, you cannot measure total lung capacity and you cannot measure FRC, functional residual capacity, because FRC, functional residual capacity, is the sum of residual volume and expiratory reserve volume. FRC is the sum of residual volume and ERV. So if you can't measure residual volume, you cannot measure FRC and TLC. But we have techniques to measure residual volume. You can use gases which will go into your residual volume and they can be measured. The gases are nitrogen and helium. So the technique is called nitrogen washout method, helium dilution technique. And there's another instrument called plethysmography, body plethysmography. So here, this is ATM like a box type of instrument, like an ATM machine. You just go into the box, you have to sit inside the box and you have to breathe. And the machine will record the values for you. So that's called the spirometry. So spirometry cannot measure residual volume, total lung capacity and also FRC, functional residual capacity. So another important topic, anticipated topic could be hypothalamus. Hypothalamus. This is the location of hypothalamus. Hypothalamus is closely related to the drop-like hanging structure. What is this gland? Yes, pituitary gland. So most of the functions of hypothalamus are related to control over the pituitary gland. So that's the most important function of hypothalamus. Other than controlling the pituitary gland, what are the functions of hypothalamus? Hypothalamus has different nucleus and the functions are also very important. So with a small comparison, quickly let's learn the functions of nucleus of hypothalamus. Let's compare hypothalamus to this car and we are going to learn the functions of hypothalamus. In a car, anteriorly you have AC and AC gives you cooling. So anterior nucleus of hypothalamus, what is the function? Yes, it has cooling effect on the body. How does it produce cooling effect on the body? How can you cool your body? You can drink water. So that's how the thirst center is present in the anterior hypothalamus, and when it is stimulated, you drink more water, your body is cooling. Or the other mechanisms of cooling, sweating and vasodilation. What about posterior hypothalamus? Look at the car. Posteriorly on the car, you have silencer which produces heat. So what is the function of posterior hypothalamus? Heating effect on the body. How can you heat your body? How can you produce heat inside your body? By shivering. Posterior hypothalamus does shivering. When you shiver, all muscles are contracting. When muscles are contracting, heat is produced. So shivering is the mechanism. Lateral hypothalamus and medial hypothalamus. So just imagine 3 people are sitting on the back seat. 2 are sitting near the window. And whoever is sitting near the window, the lateral people, wherever the car stops, they can buy some fruits or some snacks and they can keep on eating. So people sitting laterally near the window, they'll keep on eating, feeding. So the function of lateral hypothalamus, feeding. And by eating something, they'll remain awake, wakefulness. And the hormone which is responsible for this feeding, which acts on the lateral hypothalamus, is ghrelin. Ghrelin is produced by stomach and pancreas. It can act on the lateral hypothalamus and it can increase the feeding behavior. And there are also other substances called orexins. Orexins can be produced by lateral hypothalamus itself, and orexins also can increase your feeding behavior. Medial hypothalamus, just think about the person sitting medially, in the center, in the middle. The person sitting medially, he is not near the window, so he can't buy and eat. Opposite of eating, satiety. Opposite of feeding is satiety. Satiety means always in a state of stomach fullness, not at all feeling like eating. That's called satiety. But he is seeing these 2 lateral people are eating nicely, so he is getting angry, anger. He is becoming aggressive, aggression. Satiety, anger and aggression. And the hormone responsible for satiety, leptin. Leptin is produced by adipose tissue and is responsible for this satiety, stomach fullness. Arcuate nucleus. Arcuate nucleus can do both. It can increase and also it can decrease feeding. Both it can do. Increase and decrease feeding. All releasing hormones are produced by arcuate nucleus. The releasing hormones. What are the releasing hormones? They are produced by the hypothalamus. So all releasing hormones produced by hypothalamus. Which part of hypothalamus? Arcuate nucleus only produces the releasing hormones. What are the releasing hormones? CRH, corticotrophin releasing hormone. TRH, thyrotrophin releasing hormone. Prolactin releasing hormone. Growth hormone releasing hormone. All releasing hormones produced by the arcuate nucleus except gonadotrophin releasing hormone, GnRH, which is produced by preoptic area. All releasing hormones from arcuate nucleus except GnRH from the preoptic area. There's another role for preoptic area. Pre for pressure. It decreases blood pressure. Pre for pressure, and it also decreases heart rate. Pre for pressure. Suprachiasmatic nucleus. Supra. What is the meaning of supra? Top. Supra means top. On the top part of the car. What is this opening called as? Have you seen in movies? The heroine will come out of this and there's a nice song. Yes, what is the name of this opening called as? Sunroof. Sunroof or moonroof. Sunroof, moonroof. Sun and moon are related to day and night cycle. Day and night cycle is called circadian rhythm. So suprachiasmatic maintains the circadian rhythm. Circadian rhythm is your sleep-wake cycle. Supraoptic and paraventricular nucleus, O and V. So they produce the O and V hormones of the posterior pituitary. What are they? Oxytocin, vasopressin. So O and V for oxytocin, vasopressin. Both supraoptic and paraventricular can produce both oxytocin and vasopressin. Both can produce both. But if you measure the levels, supraoptic produces more of vasopressin. It's just the opposite. O will produce more of vasopressin and paraventricular V produces more of oxytocin. This is a small change. But both can produce both the hormones. But if you measure the levels, supraoptic produces more of vasopressin and paraventricular produces more of oxytocin. In the mammillary body, mammillary sounds like memory. So mammillary body, what is the function? Memory. And any degeneration of this mammillary body, which can happen in chronic alcoholism and thiamine deficiency, is called Wernicke-Korsakoff syndrome. So Wernicke-Korsakoff syndrome is a kind of memory loss due to degeneration of this mammillary body in the hypothalamus. Yes, these are the functions of hypothalamus, very important. So we have learnt it by comparing it with that of a car. Yes. Next, let's quickly move on to visual pathway defects. Very important topic in physiology and also in eye. So what is the visual pathway? Let's quickly go through the pathway and also the defects. In the visual pathway, so first of all, there is a crossing over. What is this crossing over? Look at my right eye. I'll close my left eye. For my right eye, this is the temporal field, because there's a temporal bone here. This is the temporal field or the lateral field. So now the pencil is on the lateral or temporal field of my right eye. Now the pencil is on the medial, or there's a nose. Nose is called nasal. Medial or nasal field of my right eye. Now it's on the superior field. Now it's on the inferior field. All objects on the lateral field, they will cross and fall on the middle half of my retina. Lateral objects will not fall on the lateral half of retina. They will cross and fall on the middle half of the retina. All objects medially, they'll cross and fall on the lateral half of the retina. All objects on top, they cross and fall on the inferior half, and objects down, they cross and fall on the superior half of the retina. So there is a complete crossing over. After this, they are taken by the optic nerves, and optic nerves, they have a lateral fiber. The blue one is the lateral fiber, which goes uncrossed. So lateral fiber goes laterally, it does not cross to the other side. And there's also a medial fiber. I'm tracing it in red now. The medial fiber. The medial fiber crosses and goes to the opposite side. So from both the eye, the medial fibers cross, whereas the lateral fibers, they go uncrossed. And this area where they cross is called as the optic chiasm. So if there's any lesion at optic chiasm, both the eyes' medial fibers will be cut. If medial fibers are damaged, the patient will lose temporal vision. So that's called bitemporal hemianopia. In optic chiasma lesion, both the medial fibers are cut, lateral fibers go uncrossed, medial fibers cross. So both medial fibers are cut. That will carry sensation, vision from both the temporal halves. So in optic chiasm lesion, patient will lose vision on both the eyes' temporal half. That's called bitemporal hemianopia. Over to optic tracts. So after crossing, they form the optic tracts. So this is the right side optic tract and the left side optic tract. Optic tract reaches the lateral geniculate nucleus of the thalamus. At lateral geniculate nucleus of thalamus, there are 6 layers. Layer 1 and 2 forms magnocellular pathway. Magno means big. So it is responsible for carrying bigger movements and bigger depth. Layers 3, 4, 5, 6, they form the parvocellular pathway. Parvo means small. So this is responsible for smaller details. Which is the smallest virus? Parvovirus. Parvo means small. So this is responsible for small or fine details like textures, colors and shapes. And all of this reaches layer 4 of the primary visual cortex. Brodmann number 17. On which lobe you have the visual cortex? Occipital lobe. And that's how we are able to see. This is the visual pathway. What are the defects in the visual pathway? So number 1, let's do right side defects first. right side optic nerve is damaged. If there's any damage to the right eye optic nerve, right eye you won't see anything. So on the right eye there is complete blindness, monoocular blindness. That's called right eye monoocular blindness. Left eye is normal. If left optic nerve is cut, left eye you will have monoocular blindness, right eye will be normal. The second lesion at optic chiasm. At optic chiasm, both the eyes medial fibers are crossing. So in both the eye, temporal vision will be lost. That's called bitemporal hemianopia. In both the eye, lateral or temporal vision is lost. Bitemporal hemianopia. The third type of lesion, right side optic tracts are cut. So let me just trace the optic tracts. So this is the right side optic tract. If this is cut, let me trace what are all the fibers that are there. Lateral fiber, uncrossed fiber from the right eye, which will carry from this field. This will be lost. And the medial fibers from the opposite eye carrying from this field. This will be lost. So in both the eye, left half of the world you will not see. But the lesion is in the right side optic tract. But you are not seeing left half of the world. So this is called contralateral. Right side optic tracts are cut, but you are not seeing left half of the world, opposite half. So that's called contralateral homonymous hemianopia. So if right side optic tracts are cut, left side will be lost. Left side of vision will be lost in both the eye, right and the left eye. The other type of lesion, optic radiations. Optic radiations are fibers from the lateral geniculate nucleus to visual cortex. They are called optic radiations. If optic radiations are cut, there are two types of optic radiations. Superior optic radiations. If superior optic radiation is cut, so this is going to affect only the inferior field. So that results in contralateral homonymous inferior quadrant anopia. Now you cannot call it as hemianopia. Hemi means half vision should be lost. Here only quarter vision is lost. Out of the 4 fields, only 1/4 is lost. So that's called inferior quadrant anopia. And if there's any damage to inferior optic radiation, that's called contralateral homonymous superior quadrant anopia. And this inferior quadrant anopia is called pie on floor appearance. A pie-like portion on the floor is not seen. And the superior quadrant anopia is called pie on sky appearance. On top field, you are not seeing a pie-like portion. So that's about the optic radiations. Visual cortex. If right side visual cortex is damaged, the same defect, contralateral homonymous hemianopia, but with macular or central sparing. You can see the center alone is spared. Center alone is not affected. Why center alone is not affected? Because macula of one eye has a representation in both the side visual cortex. Even if one eye's macula is damaged, center vision will not be affected because macula carries from center vision, and even if one eye's macula is affected, it has representation on both the visual cortexes. So if your right side visual cortex is going to be damaged, left side visual cortex will save the macula because macula has bilateral white representation and blood supply also is dual blood supply. So even if right side visual cortex is damaged, macula will not be affected because the left side cortex will save the macula. If macula is spared, central vision is going to be spared. So these are the different types of visual defects, very important. So the last one, let's quickly go through the hearing mechanism because in the recent INI-CET papers, we see this as a sequence-based question. All these sequences are given arranged in the proper auditory pathway order. Just a mnemonic, very easy mnemonic, echolema. Echolema, this is the mnemonic, which is the nerve which carries hearing, vestibulocochlear nerve. That's the 8th cranial nerve. And from 8th cranial nerve, how does the potential reach the auditory cortex on your temporal lobe? This is the temporal lobe near the ears. So that's called the echolema. E stands for 8th cranial nerve. C for cochlear nucleus. O for olivary nucleus, superior olivary nucleus. L for lateral lemniscus. I for inferior colliculus. M for medial geniculate body. and A for auditory cortex, echolema. So this pathway is called echolema. So this was a sequence based question which was asked. Yes, success is not final and failure is not fatal. It is the courage to continue that counts. So with this we complete our rapid session on INI-CET. So one thing I would like to say is give more importance for solving previous year questions, and not only the question, previous year topics are also very important. It is not that you know the answer for a previous year question. You should know the complete explanation for a previously asked topic. If a question is asked on transport of gases on CO2 this year, you can expect a question on transport of oxygen the other year. So it is not about the same question, it is about the same topic. So previous year topics are also very important. So try to go through at least recent 5 to 6 years of question papers and get a strong hold of all those topics. The repeated topics are very important. It's my best wishes to all of you to get your seat of choice, and my prayers also. Thank you so much for joining in this session. Thank you.